Welcome to Pulse&Pressors, where critical care gets crystal clear. In this episode, we explore the right-sided Impella, also known as the Impella RP or RP Flex. This device offers temporary mechanical circulatory support when the right ventricle is failing and can't move blood forward into the lungs. Unlike left-sided devices that unload the left ventricle, the RP draws blood from the right atrium and ejects it directly into the pulmonary artery, maintaining systemic perfusion and oxygen delivery. This device doesn't just buy time, it buys recovery. The Impella RP and its newer sibling, the RP Flex, are both microaxial flow pumps designed to assist a failing right ventricle. The RP Flex is inserted through the right internal jugular vein and uses the Smart Assist platform, allowing real-time flow monitoring and easier mobilization in awake patients. At full support, the device can deliver about 4 liters per minute, effectively replacing the pumping function of the right ventricle while it recovers. The Femoral requires a 13 French sheath, while the newer jugular uses a slightly smaller 11 French sheath. This size requirement is important for vascular access planning, as it relates directly to the potential risk of limb ischemia, which is more common with the larger femoral access. Think of the RP when your patient's right heart cannot maintain pulmonary blood flow despite maximal medical therapy. Common scenarios include acute RV infarction, postoperative RV failure after LVAD implantation, or shock after cardiac surgery. It's also used in massive PE, or when a patient fails to come off ECMO because the RV simply cannot generate enough forward flow. Right-sided Impella therapy aims to restore adequate cardiac output and oxygen delivery. Maintain a mean arterial pressure above 65 to preserve organ perfusion. A central venous pressure between 8 and 12 prevents both hypovolemia and distension. Monitor the cardiac index, and remember that a PAPI below 1 often signals RV failure, while a cardiac power output above 0.6 watts is a reassuring sign of improving contractility. The Impella RP draws deoxygenated blood from the right atrium through its inlet and ejects it directly into the main pulmonary artery just beyond the pulmonic valve. By bypassing the failing right ventricle, it preserves continuous forward flow toward the lungs. Correct alignment across the tricuspid and pulmonic valves is essential. Too deep, and the outlet may lodge into a PA branch. Too shallow, and suction alarms will trigger as the inlet approaches the atrial wall. Position is verified by echo, X-ray, or fluoroscopy. On echo, look for the inlet swirling freely in the right atrium, and the outlet resting just past the pulmonic valve within the main pulmonary artery. Fluoroscopy and X-ray shows a characteristic S-shaped curve from the right atrium through the RV into the PA. Stable purge pressures and smooth flow readings confirm proper alignment. To prevent thrombus formation, anticoagulation is maintained both systemically and within the purge fluid. Typical ACT targets are between 160 and 180 seconds. If your patient develops heparin-induced thrombocytopenia or significant bleeding, switch the purge to sodium bicarbonate in D5W while continuing systemic anticoagulation with a non-heparin agent. The purge system protects the device's motor by maintaining a positive pressure gradient that prevents blood entry. Keep purge pressure between 300 and 1,100 millimeters of mercury. A sudden rise may indicate a developing clot. A drop can mean a leak or disconnection. Continuous monitoring of purge parameters is as important as hemodynamic data. Monitor the Impella console for motor current and flow stability. Loss of pulsatility or a progressive rise in motor current can indicate malposition or thrombus at the inlet. A sudden drop in flow often signals suction from hypovolemia or migration. Addressing waveform abnormalities early prevents device failure. Weaning the RP follows the same logic as the left-sided Impella. Before reducing support, ensure adequate preload, controlled afterload, and sufficient inotropy with dobutamine or milrinone. Gradually lower pump speed while watching cardiac index and perfusion pressures. A stable cardiac index above 2.2 and improving PAPI suggest the RV can stand alone. When reducing the level, a general protocol is to reduce support every 4 to 6 hours to allow the time to compensate for the added workload. The goal is to avoid rushing the ventricle back into failure. The final test is always at the lowest setting, usually where you confirm independence for 20 to 30 minutes before decannulation. Most patients recover with short-term use, but some may transition to longer support. If both ventricles remain weak, you may move toward a biventricular strategy or LVAD implantation. In select cases, it serves as a diagnostic bridge to decision, helping teams determine long-term viability before committing to surgery or transplant. Complications are generally mechanical or hematologic. Hemolysis presents with dark urine or rising LDH. A rising purge pressure or power draw can warn of thrombus. Limb ischemia is less common with the jugular RP flex. Frequent monitoring, trending labs, and echo checks prevent escalation. Limb ischemia is a risk with the femoral approach, especially since it requires a large 13 French sheath. Frequent checks for pulses and perfusion are mandatory. This risk is notably less common with the jugular. The bedside checklist keeps the device safe and functional. Daily verification of placement prevents migration. Hourly purge checks ensure adequate lubrication and thrombus prevention. Trend hemodynamics every few hours. Any drift often signals a physiologic or mechanical issue long before alarms do. The right-sided Impella restores balance to a failing circulation, supporting the right heart so the lungs and left heart can do their job. When used correctly, it transforms otherwise fatal shock into a survivable bridge. This is Pulse&Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.